Hi, you're very welcome to our episode of The Scope, which is a series looking at the science, medicine, business and politics of healthcare. And tonight we want to focus on prostate cancer. I'm delighted to welcome my colleague, Professor Juanita Crook, who is a professor of radiation oncology at the University of British Columbia in Vancouver, Canada. And Juanita is a real expert on prostate cancer, and particularly the use of radiation and brachytherapy, which we'll get into in the management of this disease. So Juanita, thank you for joining us. It's great to have you.
Thank you. It's a pleasure.
So look, we wanted to really focus our discussion on prostate cancer. And for the purposes of introducing the topic, I thought I might start out for our patients by saying, if I was a patient who was just diagnosed with this condition, I'm 65 years old and I'm in good health, and I've just been told I have a localized form of prostate cancer. What are my options to manage this condition?
If you're going to look at definitive treatment, there's basically surgical options and radiation-based options. And I would advise any man who has just been diagnosed, and who usually sees a urologist first, they're the ones that arrange the biopsies and do make the diagnosis and transmit the information to them. And they're going to talk about surgery. But before making a final decision or just going along with what is suggested, they need to explore their options. They need to see a radiation oncologist and find out, what else they could do. Because that, they may still go back and choose surgery, but that makes an informed patient who's going to be a much happier patient no matter what happens. Because he said, I knew about everything, I chose this, and this is what happened.
So in this situation, I was told that I had a good risk, cancer, but one that needed treatment. And some of my friends were advising me to consider something called brachytherapy. Could you just talk a little bit about what that is and why I might consider it?
Yeah, I think that's actually very good advice. Brachytherapy is one of the radiation options, and it's an internal form of radiation. Most radiation treats from the outside in, so you lie under a machine and it beams the radiation in from the outside over several treatments that usually span, daily, Monday to Friday for several weeks, whereas brachytherapy treats from the inside out. So what you're doing is actually placing the radioactivity, the tiny radioactive sources, directly into the prostate and specifically into the cancer, and that allows us to deliver a much higher dose than we ever could using an external radiation approach. And that's what makes brachytherapy so effective.
Great, and I also understand that it can be done in a day procedure in the hospital, as opposed to requiring admission for several days. So there are certainly advantages there. But what about the risks of this approach and the risks of the cancer coming back with brachytherapy, say, versus surgery?
Well, brachytherapy, especially in the form of what we call a low dose rate permanent seed implant, and don't confuse low dose rate with low dose. A lot of people are with the low dose brachytherapy. The seed implant, which gives its radiation very, very slowly over a long period of time, delivers an incredibly high ultimate dose. It just does it very, very slowly. And it's this high ultimate dose delivered over a 6-month period that makes it so effective. This form of brachytherapy has been around now for almost 3 decades, 20 years, 25 years. And people have been followed closely in many, many centers over that period of time, mapping out their PSAs. And we've learned that men treated with this form of radiation really have what we consider an ablative form of treatment. The PSA is going to go to surgical levels. The median PSA 10 years out is 0.0 something. So it's a very, very low PSA, and it's maintained that way over extended follow-up. So this is a curative procedure and a very, very effective one.
So now, I know you're the lead author and the lead clinician on a recent study which has just come out in the journal Radiotherapy and Oncology, and it addresses just this issue. What are the main findings of this study?
Well, myself and my colleagues and those that deal with brachytherapy have noticed over the years, as I was just saying, that these men achieve extremely low PSAs, and these PSAs are stable over many, many years, extended follow-up, 10 years, 15 years. And the problem with PSA after radiation is that we don't have a PSA definition of cure. That has never been established. We've kind of avoided that. There have been a couple of big conferences that put together definitions of failure. How do we find when a patient has failed their treatment? And so we've established that, and we all follow these rules for especially external beam radiation patients. But the consensus panels that developed these definitions of failure never tackled, can we really define through PSA if a patient is cured? And so having observed these really, really low PSAs in so many patients over so many years, we got together and from 7 different centers put together 14,000 patients that had 10, 15-year follow-up and looked at what their PSAs were and to see if we could define what PSA predicted whether that patient would remain free of any evidence of prostate cancer out of 10 and 15 years. And so that's what we've just published. And what we found out was that if the PSA relatively early on, at 4 years or 5 years after the brachytherapy, is less than or equal to 0.2, and it's going to go a lot lower than that, but even if it's down to less than or equal to 0.2 at 4 or 5 years, that person has a 97 to 99% chance of being free of evidence of prostate cancer at 10 and 15 years. So that has huge implications. It means, A, the patient can stop worrying. They may want to still follow a PSA, but even, some might elect not to. They certainly don't need regular follow-up visits with the cancer center. It has a lot of implications.
Now tell me, why did you pick 0.2 for this study?
Well, we looked at what the various PSA levels that we could use would be, and there have been previous studies looking at 0.4, and that works almost as well, but there's a slightly higher failure rate out at 10, 15 years, so that's not quite as definitive as a 0.2. And basically, we settled on 0.2 because, first of all, that's how the surgeons, after radical prostatectomy, define a failure. So if we now have a level playing field and we're both talking in the same definitions, it's much easier to compare surgical and brachytherapy results directly. When you have different definitions of failure that may take longer to achieve, it's harder to say, well, you have more people failing than we do, but you're looking at it at a different time, and all those things are different, and so it makes it much more complicated. But if you're calling a spade, 0.2 or not 0.2, then we can compare them much more easily. If we chose that definition, also a lot of people were in that group. Almost 80% of patients would achieve a PSA less than or equal to 0.2, but there's still, even in the highest PSA group, we looked at less than or equal to 0.2, 0.2 to 0.5, 0.5 to 0.1, and over 1. And even in the over 1 group, there were still 5% of patients. So it dispersed our patients not into equal subsets, but into subsets where there was still a significant number in each group.
And do people have to wait 4 years to get that number? Why does it take so long after brachy versus, say, after surgery where, within a couple of weeks, a patient may know whether they've got a cure or not?
Well, first of all, radiation doesn't kill outright the prostate cancer cells. It damages them so that they cannot successfully multiply in the future. And the growth rate of prostate cancer is fairly slow. So it may be several months, maybe a year, maybe even longer before an individual cancer cell within that tumor that has been successfully treated goes through its next cell division and finds out that it's got a fatal error and it can't successfully replicate. So it takes a while for the full effect of the radiation to be experienced or expressed. And the other thing is that patients treated with permanent seed implants, the low-dose rate brachytherapy, often experience a phenomenon called a benign PSA bounce. We still don't fully understand this. We think it's an inflammatory response in the prostate, but the PSA can be coming down very, very nicely for 6, 12, 18 months, and all of a sudden it turns a corner and starts going back up again. And we know from experience, patient had a good implant, let's just watch this, see what happens, and it'll go up for 2 or 3 readings in a row, and then it'll go back down again and reach its true nadir or lowest point, several months later. So we didn't want to be including people that were in this bounce range, and most bounces happen before 3 years, in the 2 to 3 year range. So that's why we wanted to wait long enough to let all this perturbation settle down and look at a 4-year result.
So we were very privileged to have, I think, a little around 700 patients from Ireland participate in this study, which is brilliant for us because it means we can now talk to Irish men directly and promise them that kind of good result. I know your group is from all over. Could you describe, the breadth of the group and why it's important to have people from multiple countries participate in these kind of studies?
Well, you want to know that the result is reproducible, that it's not limited to certain details of technique or isotope or something like that might be different in one country versus another or one university versus another. So that's why we wanted to make it as international as possible. And it was great having you guys, from Ireland participate in that. There were 2 sets of data that came from Canada, one from Toronto and one from British Columbia. So it is a very valuable data set, and what we're hoping to do next is look at definition of risk groups for men with prostate cancer who are treated with brachytherapy. Our current risk groups of high risk, intermediate, and favorable were defined for patients treated with external beam radiation. And they may or may not be directly applicable to people treated with this much more intense form of localized radiation with brachytherapy. So we want to see if those same predictive factors of PSA and T-stage and Gleason score could be regrouped somehow to help determine what the best treatment is for these men.
Great. Well, listen, I just want to close by saying this data is really useful for us in our clinics. I know that patients that I speak to are very reassured when they see and hear these numbers because we follow patients lifelong, of course, and it's even when the treatment has been several years earlier. When I tell them the numbers and the fact that they're well under 0.2 at 6, 7, 8, 9 years past, they're really delighted to hear that those findings are going to be durable. So I think it's been a great study to be involved in, and I want to thank you for all your effort and that of our colleagues in putting it together, and I look forward to more work to come.
You're very welcome. Thank you.
Thank you, Juanita.